Hello, everyone. I'm Carmen Pugliafito, and I'm here today with Dr. William Harbour, who is professor and chair of ophthalmology at the University of Texas Southwestern Medical Center in Dallas. And he is a recognized authority on the management and diagnosis of choroidal melanoma. Welcome to Retina Synthesis, Bill.
Thank you, Carmen.
So the last decade has been a real revolutionary one in terms of the management and diagnosis of choroidal melanoma. Can you give us a 35,000 feet view of what's gone on to start off with?
Sure. Yeah, I think that the field of ophthalmology and ocular oncologists in particular, I think have been pretty good at diagnosing typical uveal melanomas for the last 30 years or so, and the collaborative ocular melanoma study showed that about 98% of patients entered into the collaborative ocular melanoma study that subsequently underwent a nucleation were found to truly have a uveal melanoma. So I think for typical tumors, we've been pretty good at diagnosis, but I think what was missing is the understanding that uveal melanoma is really not one cancer. It's really several different subtypes of cancer based on their genetics. And we've really made a lot of progress in the last 10 to 15 years in understanding that while they may look very similar clinically, when you look at the genetics, there are different types. So there are two main types that, based on gene expression profiling, which is most of the work that I focused on, we call them class 1 and class 2. Class 1 being better prognosis, class 2 being worse prognosis. And then within each one of those groups, there seems to be a subgroup based on the amount of aneuploidy or chromosomal alterations within the tumor. The ones with very little turn out to be negative for an oncogene called PRAME, and those that are positive are positive for this that are positive for PRAME have more aneuploidy. So you end up with a kind of 4-stage system: a class 1 negative, class 1 positive, class 2 negative, class 2 positive. And with that, you can do extremely accurate prediction at the time of diagnosis of which patients are most likely to metastasize and those that are least likely to metastasize. And then what the next frontier really is to use this technology not just to stratify patients with obvious melanomas, but to use it to look at suspicious nevi. So, for every melanoma, there are numerous people with a suspicious nevus out there that we're not sure what to do with. We know that melanomas metastasize when they're very small, but if we start treating every small tumor, we're going to mostly be treating benign nevi. We try to use clinical criteria to pick out which nevi are actually small melanomas. We look at the fluid and the tumor thickness and orange pigment and lack of drusen and things like that. But as I showed in my AOS thesis a few years ago, even using all of these criteria, if you compare that to genetic criteria, they're not that accurate. So they're the best we have, but they're not that accurate at picking out which of these small tumors are actually melanomas. So the next frontier is really to take this classification, this molecular genetic classification that I described, and to use it to determine which small tumors are small suspicious nevi are actually melanomas versus nevi. So we're at this interface where we need the clinical knowledge, but we need to compare that to the genetic information to know which patients with melanomas are at high risk and need further management, and then which patients with small lesions need to be treated versus those that can be observed.
What's the profile of the small, of the nevus that needs to have this kind of diagnostic evaluation?
Yeah, so right now we are gearing up to do a prospective validation of what I'm about to tell you, but the current state of knowledge is that if you have a small tumor that ends up being class 2, then in my practice, I go ahead and treat that lesion, even though it may be small. If it has a class 2 profile, which, it must have had some risk factors if I even biopsied it. So it probably had a certain thickness or subretinal fluid or evidence of growth. But if it's class 2, I would recommend definitive treatment, usually with plaque radiotherapy. If it's a suspicious lesion and it ends up coming back class 1 PRAME negative, then I observe those patients and look for growth, but generally don't treat those. The real question is, what do you do with a class 1 PRAME positive? Because we know that the class 1 is good, it's a low risk tumor, but when it's PRAME positive, that means that it's likely to acquire more genetic aberrations, to be genomically unstable, and to continue to evolve. So this is not a evolutionarily dormant tumor. It may continue to change. So that one we don't know the answer to yet. In my clinical practice, I describe the situation to the patient and have a discussion with them at whether we should go ahead and just definitively treat it or watch it closely, or maybe try another therapy that's less visually threatening than radiation, such as PDT or TTT, or this new Aura Biosciences therapy that's still in clinical trials. So we're still sort of figuring out exactly what to do with this information, but we're performing prospective trials to give us the evidence that we need to develop clinical standards.
So for the higher risk tumors, the small ones, does definitive treatment affect the natural history of the tumor?
It's a great question. I think the answer is yes, based on the fact that if you look at 5 to 7 year follow-up of patients, let's just say with class 2 tumors, those that were class 2 but had a very small tumor have a much better prognosis than those with a medium or a large tumor. And part of that may be lead time bias, but as we follow these patients for longer and longer and longer, we're not starting to see a lot of these small class 2s metastasize. So while there may be some effect of lead time bias, I think that many of these patients were actually curing, these ones with small class 2 tumors. And the size is sort of a reflection of how long the tumor's been there, how long it's been allowed to grow and accumulate risk for metastasis. So the smaller ones that we're treating, we have indirect evidence that yes, we're affecting the natural history. The study that we're preparing to do now will be able to prospectively evaluate that hypothesis.
So if you have a definitive choroidal melanoma, what's your molecular evaluation of that eye? What do you tell the patient? And what tests do you specifically do?
Yeah, so if I have a patient who has a definitive uveal melanoma, I have that discussion with them and say that you need to have treatment. Most patients, about 90% or more in my practice, will get plaque radiotherapy. About 5% will get a nucleation, and the rest may get something else, but the vast majority are going to get plaque radiotherapy. And I tell them that regardless of the genetics, we need to treat this because it can continue to evolve even if the genetics are good. But when we go in to do your surgery, we should do a biopsy at that time to evaluate what subtype you are. And if you're in a high-risk subtype, then number one, we will give you more intensive surveillance. So we will monitor your liver particularly more frequently and with an MRI typically rather than an ultrasound. That patient will also be counseled on available clinical trials. There haven't been a lot of options in the adjuvant trial space, but that's changing. It's going to change very soon. There are a number of drugs that have shown promise in the systemic setting. The Immunocore drug Tebentafusp, the IDEA drug that Taro, which is coming along, and others. So there very soon are going to be options in the adjuvant setting for patients with high-risk primary tumors. So those patients will be counseled on what their options are, and whether or not they want to get into a clinical trial. They will be encouraged to have more intense surveillance. There certainly is evidence that if somebody develops metastatic disease, they do better, have a better overall survival, and they have more treatment options if we catch it early when they only have a few metastatic lesions versus if we catch it late. If somebody, going back to this patient, at the time of surgery for their eye tumor, we do the biopsy. If it comes back low risk, class 1, PRAME negative or PRAME positive, we will still recommend surveillance, but less intense surveillance. And that ends up being about 2/3 of patients. And these patients don't need an MRI every 3 months. They only need an ultrasound typically every 6 to 12 months. So this is one reason why the test that I developed and licensed, the Castle Biosciences test, has been accepted by Medicare and most third-party payers, because it actually saves them money on 2/3 of the patients who actually don't need as intense surveillance as they otherwise would get.
What are the next horizon of the molecular diagnostics?
I think the next horizon is liquid biopsy. And liquid biopsy could take the form of ocular liquid or ocular fluid. Aqueous would be ideal. The other form, would be blood. That would be the low fruit, so to speak. There might be other bodily fluids that could be looked at, but those are the two that are being focused on. And I really view them both as being complementary to the tumor biopsy. I don't see them as replacing the tumor biopsy. But for example, if we could find biomarkers in the aqueous that tell us that it's more likely that a suspicious nevus may actually be a small melanoma, then we could use that as a threshold for doing a tumor biopsy. And the analogy I use is with the PSA test for the prostate. A PSA test is not nearly as useful as a prostate biopsy, but we don't use the PSA as a substitute for the prostate biopsy. We use it to look for a change in the PSA, a rise in the PSA, and then that signals the need to do a prostate biopsy on a subset of at-risk patients. So that's the way I would see the use of an aqueous liquid biopsy is, we'll say that somebody has a suspicious nevus and you see them in the office, you could do an aqueous liquid biopsy test. If it comes back low, then you keep watching. Maybe you repeat that test once a year or once every 6 months. And if that test starts to change, then that might signal the need to do a tumor biopsy. For blood liquid biopsy, I see a different use there. Again, we've looked, others have looked. You really can't find enough circulating tumor DNA or other biomolecules to replace a tumor biopsy. The rich amount of information we can get from a tumor biopsy in terms of gene expression profile, PRAME, we can look for all the driver mutations, and we can look for chromosome copy number changes from a single 27 gauge needle biopsy. There's no way that we're going to replace all that with a blood-based circulating assay. However, what we can do is use that, for example, to look for tumor burden. So let's take a patient who has a high-risk class 2 PRAME positive tumor. We check their circulating tumor DNA and we don't see any. Maybe you repeat that test every 6 months and you look for a change. If you start to see an increase in tumor DNA in the blood, that could herald the onset in the near future of overt metastatic disease. And that's already been proven by several groups that you can use circulating tumor DNA to detect metastasis several months or more in advance of it being evident on imaging studies. So that would be one use of a blood-based biopsy, is to give you an early warning of somebody who's going to have metastatic disease, maybe get them on therapy earlier. The other is to monitor their response to therapy. So the Immunocore trial with the drug tebentafusp really beautifully showed the value of circulating tumor DNA, in that the patients who responded to tebentafusp, which is, as of now, the only FDA-approved drug for metastatic uveal melanoma, it showed a substantial benefit in the metastatic setting. But the patients who responded are the ones who cleared their circulating tumor DNA. And it wasn't even the patients who had a response on imaging. Sometimes the tumors didn't really go away on imaging. And the thought is maybe that you're getting an immune reaction, and the tumor cells are dying, but the lesion is still there on imaging because it's inflamed. But if you see a clearance of the circulating tumor DNA, those are the patients who are getting a good response to therapy. So I see liquid biopsy as the next frontier, but we have to figure out how to use them. We can use them before the definitive tumor biopsy, primary tumor biopsy, to detect which patients need a definitive tumor biopsy for small tumors. And then we can use it after the definitive tumor biopsy for high-risk patients to monitor which ones are maybe about to get metastatic disease and which ones are responding to therapy.
Well, this has been a fantastic discussion. Congratulations on the great work that you've done, and really demonstrating that molecular biology can really contribute in a very dramatic way to the management of clinical disease. Great job.
Thank you, Carmen, for your time. I appreciate it.
Thank you.